the session is over.
Okay, fine. Done. Done. And this will be the slides will be projected by Anita from your end only. All the slides, right?
Yes, sir. We are like doing the live, and once after the session, I would be sharing the link of the session also where it was live stream, and that will be accessible by whomever we are sharing it with.
No. Like
Slides,
this
slide deck.
slide.
Sorry, sir, I couldn't get. Can you come again? I'm extremely
This
sorry.
is the presenter's slide deck.
Oh, sorry. Okay, the presenter slide deck, only the introduction of the faculty slides we are sharing, sir. The presenter slide deck are shared by the faculties only. If it is required, if the slides are with us, our technical team will be sharing it with, sir.
Sir,
So
if you want, they will project your slides, sir, and share it to them.
Yes. Huh.
okay.
आपका slide, shall I share it to them, sir, with your permission to project?
I mean, it can be done, but I can share the slides. I can share no issues. I will share no issues.
Okay, fine.
That is fine. So I was just clearing that what. So for others also, they will share their own slides. That is fine.
Yeah.
I hope though they have been aware of that. I mean,
Yeah, yes, sir.
okay.
So, Anita, totally how many registrations we have?
So we have over of around 642 registrations, sir.
Good. Okay.
Huge number,
That is
yeah. Very huge.
People are still joining. We have just sent a reminder, so like parallelly it will be increasing, sir.
A huge number of people here.
Good evening, sir. Good evening, Srikanth.
Hi, good evening. How are you?
Fine, sir.
Hi, ma'am. Good evening, ma'am. How are you?
Good evening. Fine. I was trying for the last 5 minutes. When
Oh,
Neeraj sir has joined, I joined, but somehow there was some problem. Now it is clear.
great.
I think Dr. Vijay Okay. After a long time, sir.
Yes, it's been a long time. Running around here and there, what to do?
Sir, yesterday from Unipath, I forgot her name. Someone has presented online here regarding pre-analyticals of NGS.
Is it no, Dr. Pavitra?
Yes, Dr. Pavitra. But it was on online. She presented from there.
Okay.
So, but yeah, Dr. Pavitra only, correct.
Dr. Pavitra also. I was not there.
Ah,
I hope
that's
it
what I
was
was. It was good. Sir.
useful. It was useful,
Mm.
kind of.
It is. No, it was useful. And as far as I understood, she worked more on the biobanking system. I understood that.
Okay, okay,
That's what my understanding is because I joined in the mid.
okay.
but it was useful.
Some voice is breaking down in between. Yeah. Is it some connection issue, or I am clear, or Dr.
You are,
Lavanya is not?
you are very clear, sir. My voice is not audible.
No, it is breaking in between.
I think there is
Your
network
voice,
issue.
it's fine, sir. Your voice is fine, sir.
No,
Okay.
sir is saying my voice is breaking.
In between at points is what I realized.
Maybe this is because the mic is so close to your mouth.
Okay. Now is it okay?
Yeah. When voice is fine like that, but little bit disconnect at certain time points.
Sir, inside the lab, we do have some
Ah.
network issues. So that is by default.
I think we are only 4 minutes.
Ah,
Hi, ma'am. Good evening, ma'am. Dr. Vijayaksh, ma'am.
where is she?
Yes,
She's
joined.
joined. Hi, Dr. Vijayalakshmi.
How are you all?
All well, all well. How are you?
It's a pleasure to meet you, Dr.
Same
Neeraj.
here. Same
Yeah.
here. E-meet.
Thanks to Srikanth, he brought us all together.
Yes.
Hi, Lavanya. It's such
Hi.
a pleasure to meet you, Lavanya.
Yes, of course. Sir, she's my super senior in my PhD.
Oh, great.
Lavanya and myself, we belong to the same family, sir.
Which
Oh.
PV?
Yeah, very happy. I'm very, very happy to see her.
Actually,
Thank
we
you.
all belong to the same molecular family.
Yes, sir.
Yeah.
Yes. That's a very nice way of putting it. Yes, yes.
No, good, very good that you could connect.
No,
Yes.
sir, that shows how strong the roots are there from Chennai, Adyar.
Yeah.
So,
But I think, to tell you frankly, you're such an inspiration to me, Dr. Neeraj. I kind of follow your publications. The way you're.
Yeah, your voice is I'm not clear. I mean, is it to me only or
Sir,
anyone
is it?
else also is this
voice is
finding
very
voice?
clear, sir. I can
no,
hear
her
very
voice is,
clearly.
yeah,
Clear,
her
sir.
voice is clear, sir.
Clear?
Yeah.
Yeah.
Clear.
I was saying that you're my big inspiration, sir, as far as molecular testing goes. We discussed so much about you when, even from Unipath, when people were there, we had a lot of discussion about you and the way you're taking up the testing and the way you think and interpret. I'm following your publications also closely, and it's really nice in a way. Like we want to have a facility in future, like what you are doing in Unipath. You are our kind of a yardstick for the country.
No, thank you so much. These are two good words. This is good to know, but a lot of things to be done, and we can certainly discuss whatever is required. We can
Yes.
always discuss that.
Yes. Yeah. If you can excuse me for 2 minutes, I'll be back.
Yeah, please. I think we are just starting. 1 minute left.
Yeah, sure.
Even Dr. Suruchi has also joined.
Yeah, I think.
Good evening, Dr. Suruchi.
Good evening.
Hi.
Good evening, Dr. Neeraj. Hi.
Very good evening.
Good evening.
Hi, Dr. Suruchi.
Hello. Hi. Hi, Srikanth. Thanks
Hi,
for
Dr.
giving the
Suruchi.
opportunity.
Good evening. So we have full faculty.
Thank you for taking time out to teach us. Thank you.
It's okay. It's my pleasure. Thank you.
So Anita, we have 1 minute left out.
It's sharp 7 p.m. With the permission of Dr. Neeraj sir, can I go ahead and initiate the webinar?
Yeah, give me a minute here. I mean, I'm not able to get little bit clearly. So, is my voice clear?
Yes, sir. It's absolutely clear to us.
Okay.
Yes, sir.
Then-
Your voice
then
is
we can
clear,
go.
sir. Your voice is clear.
So your voice is breaking to me. Your voice is breaking. That is why I was little concerned.
No, sir. Sir, your voice is very clear. Not a small disturbance.
Okay.
I
Then we
think
can go ahead.
your speaker
Yes,
or
I'm
something
back.
is.
Okay. Thank you all. A very good evening to one and all present here. And thank you all for attending this webinar. I would like to invite Dr. Neeraj Arora, Honorable Secretary, Molecular Pathology Association of India, for setting the context and moderate the event. Over to you, sir.
So Very good evening. Thank you, Anita. Very good evening to all of you. And thank you for joining. On behalf of MPI, I would like to welcome you all the delegates and the speakers for taking time out for this important session. Today, this session is on, as you are aware, this is mainly we deal with the pre-analytics and the impression in precision medicine. As you are aware, the title of the topic. And MPI as an organization, we have been conducting a lot of seminars in this area because we realize pre-analytics is one of the most important area, and we all need to learn a lot of things. So with that education intent, we have been holding webinars in this area. And thank you, AstraZeneca and the faculties who have agreed to be a part of this. This is the last series of the webinar, and I would like to thank you all for attending this one. And we have realized whenever in this era of precision medicine, one of the challenging areas that we as a country we face is specifically in the biomarker testing is the pre-analytics, and we all need to be educated, be it pathologists, be it radiologists, clinicians, and we all face those issues whenever we are amplifying our tissue specifically, and we collectively need to see or implement changes in our protocols so that we all get good results for our patients. So with that intent, this webinars have been done, and this is the last series. And we have learned faculty. We have learned faculty which includes Dr. Vijay Lakshmi, Dr. Suruchi, Dr. Lavanya, who will be sharing their experience. So I will the webinar is structured in a way that I will be taking you through the introduction part and introducing you to the pre-analytic part of this thing, and subsequently we will have uh, best practices being shared by the faculty. So without wasting much of your time in this area, I'll start on the webinar. Okay, I hope everyone can see my slides. Okay, uh, so uh, as I mentioned that the topic is pre-analytic issues and its impact on molecular testing, and I will be taking you through these aspects. So the learning objective in this session is we would like to learn in the way in which the specimens are handled and processed for molecular testing. Then what kind of things we can prevent to reduce the artifacts which are introduced during this pre-analytical stage, and also would highlight the broader steps of collection, stabilization of tissues, cytological and blood samples. So we will be learning all of those in this session. So in the phases of biomarker testing, like for molecular biomarker testing, there are various stages, and we have a pre-analytic stage. So there are three phases, and that is true for any laboratory processes. One is pre-analytical, analytical, and post-analytical, and all of them should be carried out in the proper context to be able to get good results for our patients. So we tend to focus more on analytical and post-analytical part, like how the test is done, what is the techniques to be used, and how we need to report, and what are the things in that. And one area which is always neglected is the pre-analytics, and of all the people who have been involved in molecular testing, all would agree the key area or the steps which makes the maximum impact is the pre-analytics. If we are able to improve upon our pre-analytics, we would go be yard ahead, or we would be uh, more efficient in getting the right result. So that is where we are focused today. That is pre-analytic errors. And if you are able to control and standardize the sample handling during the pre-analytical phase, we will be able to get more reliable test results. So, as I mentioned, there are three phases. One is pre-analytical, analytical, and post-analytical. Analytical primarily includes the pre-analytical mainly includes the sample collection and stabilization, sample processing and management, sample transport, and to an extent sample storage as well. And then we have analytical where we test, and then post-analytical where we report. But the maximum impact that any laboratory or errors with respect to errors is pre-analytical, and we tend to understand those issues little late. And what happens is that you all realize in the end when the PCR fails or when the test doesn't give the correct results, and then only we realize, okay, the PCR is not working. What is the issue? And then that is the time we tend to start evaluating what is the issue, and we realize that there has to be a wholesome changes or wholesome things need to be worked upon in the area of pre-analyticals, and there are a lot of process, a lot of people are involved in that, and that is why a correct understanding and knowledge of this step is required to be able to correct this. So within the aspect of sample collection and stabilization, there are things which we need to be aware of that, and all of them we need to be standardized. First is awareness. I am not sure how many of all the people are aware, and this primarily rests in the hand of pathologists, because they are the primary people who deal with the tissue, and tissue always remains an issue in the molecular lab. So understanding and knowledge of the tissue processing first hand is very important. And one of the key steps is, or key thing is, time to stabilization. That is the cold ischemia time. So there are two types of ischemia time that are known. One is hot and one is cold. This is the time that is time involved in once the sample has been taken out to the fixation. So the hot fixation is the time taken when the artery is ligated to it is taken out, and the cold is when it is taken out to fixation. So this cold ischemia time is very important, and this has a role, and we need to be aware that this has to be less than 1 hour. That as soon as the tissue is out, we need to fix it in the appropriate fixative agent. In what volume of specimen this fixation has to be done, what is the type of fixative, and the time in the fixative is there. So this is also very critical. The sample needs to be dipped appropriately in the specimen, and this is more than 1 in the ratio of 1:10 would be an appropriate, and all of the sample should be dipped in the fixation, the fixative. The type of fixative, we are aware of so many types of fixative, but for molecular testing, 10% neutral buffered formalin is kind of sort of recommended fixative. And I cannot emphasize the role of time in the fixation. So we need to be aware about volume, type of fixative, and the amount that we do, amount of time that the tissue is kept in the fixative. And this is different for the biopsies, and this is different for the larger specimens. So it will differ depending upon the type of tissue that we are using. And anything less than 6 hours to anything more than 36 hours can destroy the results of whatever we are doing. And the difference between right results or accurate results of this could be in the test would be in the range of 1 lakh, 2 lakh fixation time. And that when we are processing FFP specimen, we do not have that kind of information available. So as a pathologist or people involved in processing of the tissue, this is very, very important to document what volume, what type of fixative, and how much time this is fixed. Sometimes during holidays, in a larger specimen, we tend to overfix it more than 2 days, more than 3 days, and may lead to the tissue not being amplified and tissue being useless for subsequent molecular testing. So this is very, very critical and important to know fixation, type of fixation, and the amount of time this sample is fixed. So what then subsequently the quality of the processing fluid that we use, what paraffin type, and what is the paraffin temperature, all of them have an impact on the quality of the DNA or nucleic acids, DNA and RNA that we extract. And we need to use the right kind of paraffin. Any compromised paraffin, any low quality paraffin with the melting temperature very high or very low may lead to the test not being working. And these things we don't get to know from the blog that we receive or the blog that we prepare. But again, this pre-analytical, we need to be aware of these issues and we should aim to correct them. Another important is the specimen management. As you know, in the smaller biopsies, like lung specimen, where nowadays we have a lot of biomarker or molecular testing like ALK-ROS, RET, EGFR, BRAF, KRAS, lot of biomarkers available, and tissue from smaller sections. We need to do a lot of tests from small, scanty biopsies. Not only we have to diagnose, we have to do IHC subsequently, and then do molecular testing. So our specimen management practices have to be aligned with whatever needs to be done in the context of the patient. We cannot just waste any tissue, specifically in smaller biopsies, even in larger biopsy sections as well. But very, very critical in the smaller biopsies where we have to do so many things. And then then the appropriate transport things needs to be the sample storage and transport needs to be taken care of, because if those results are again not right, the transport is not right, the storage is not right, they can lead to false negative results and very, very important results. I think last, like the TRF information, I cannot highlight more. Anyone who works in a hospital setting, it is slightly different, but anyone working in a lab, it is slightly different. And I cannot emphasize the role of complete requisition form or TRF form, where the details of the patient, including the clinical details and the samples, and those are properly labeled and provided. Otherwise, again, this leads to a lot of issues. So a simple TRF form could have a huge impact on whatever tests are being done. So we all need to be aware that these essential pre-analytical factors like cold ischemia time, method of stabilization, method of processing, specimen management, sample storage, and transport. Not only transport, once we are shipping the sample to the lab, post-test storage also is very, very critical. What kits or what sample, how we are storing that is also very, very critical, and I'll discuss that in the subsequent slides. So as I mentioned, the once the tissue is taken out from the body and is stabilized or being stabilized or taken for any molecular testing, the one of the first important step is the cold ischemia time, and anything more than 1 hour can compromise the results. And not only you, we all need to be aware of that. And as a clinician, we need to engage with the clinician who are taking these specimens out, and we need to be aligned in that way that this results, the cold ischemia time more than 1 hour might affect the immunohistochemical and the molecular test, and this has to be less than 1 hour is recommended by most of the experts who have been working this area. And this helps to prevent the degradation of proteins and the nucleic acids that we tend to extract. And degraded nucleic acids, once we get, they can cause issues in amplification and also gives false results as well. So this is a slide or a representative publication which shows the impact of cold ischemia time, the time taken from the specimen to the fixation. So if it is prolonged, it can affect the results. So this is the biospecimen surgery, which is immediately fixed. You can see the IHC or the phospho AKT being lost after a certain time points. So these results are to evaluate that, and this has an impact not only on the IHC but also on subsequent molecular testing as well. Just to share that this time is very important, and we all need to be aware. Even we don't practice sometimes or be aware, but we need to be aware and minimize this cold ischemia time well. And this is mainly working with the surgical surgeons who are taking those samples out. The other thing that I mentioned is the tissue samples must be immersed in appropriate fixative, and 10% pH neutral buffered formalin is what is the preferred solution which is recommended, and this helps maintain the adequate quality and quality of the DNA which we use for our molecular testing. And 70% ethanol, which is kind of used in cytology specimen where FNSC detail is crucial. So this is another reagent which is there for cytology specimens, and the thickness that is described should not be more than 4 to 5 mm, and acid decalcification is contraindicated for molecular analysis of nucleic acids. So specifically bone tissues or bone marrow biopsy specimens being sent for different kind of tests. It could be biomarker testing, it could be clonality testing, it could be different kind of analysis being done, but a decalcified specimen more or less fails from what we get in the laboratory, and therefore whenever such a specimen is referred to us, it becomes very difficult for us to give the results. So we all need to be aware, and if at all decalcification is required, then we need to use an EDTA as a appropriate fixative, and this sort of EDTA specifically in bone marrow biopsy specimens, and there are publications from different subgroups which have shown that EDTA as a fixative or as using in terms of decalcification, those kind of bone marrow biopsy specimens work well for downstream lot of molecular assays available. So this is with respect to the fixative. The fixed amount of time required for fixation, as I mentioned, under fixation, and this is dependent upon the type of biopsy specimen we choose. It could be a small biopsy specimen, it could be a large biopsy specimen. So fixation will vary depending upon the size of the section, the size of the biopsy, and minimum 6 hours fixation is required. Sometimes we tend to process samples very urgently. We require urgent results, but believe me, they do more harm as to good. And getting the same specimen again, we have to re-biopsy again. I mean, that causes a lot of issues and problems. So under fixation, less than 6 hours may not help you get you good results. Over fixation as also may not give you good results. Anything more than 2 days or more than 36 hours is what is recommended. But in practical terms, more than two days, it leads to issues with the downstream molecular testing for any type of molecular testing. But and this typically happens with larger specimens like the colon specimens. Larger tissue samples are there, and where as pathologists we want to fix them well. So in those scenarios, having additional block, so one block could go in for an IHC and one block could go in for a molecular testing, which is removed within the specified time, and this could be worked up in the laboratory. So that could be very helpful, having 2 blocks, one going for IHC and one going for molecular testing with the right amount of fixation. So this is very critical. How much fixation, and you waste a lot of time, money, and effort, and then you realize the fixation could be a problem. See, then the procedures with fixed specimens and procedures and materials for specimen processing should be standardized, and the more the automation it helps. As I mentioned, the paraffin type of paraffin, the temperature of the melting temperature of the paraffin is very important, and the high quality paraffin uh, with that liquefies at low temperature less than 60 is what is recommended. So we need to be aware of what paraffin we are using for our blocks. Otherwise, our results would be compromised. And when I mean compromised is that, we take sections from the block. There's a lot of paraffin. We deparaffinize that, and still though there are impurities left, and those impurities which are there, they go into the extracted DNA. And those inhibitors or impurities, if we use it in our section, in our the assay does not amplify, the NGS assay does not amplify, the routine single gene testing does not amplify, and then we are left with, we cannot control that later on. We are in a state of section. I mean, we cannot do anything later on. So it is prior to that, if we are able to control, that would be the best thing to do. Other thing that I mentioned is the sequential sectioning in this. So especially smaller biopsy sections, we need to be very aware that H&E or again, we cannot overemphasize the role of pathologist here. I cannot emphasize the pathologist is the most important person. We all would agree, where H&E staining not only gives you assessment of the diagnosis, it helps you define the cellularity, what is the tumor cellularity, and subsequently based on your assessment, once we have made a morphological diagnosis, subsequently taking right amount of sections for further immunohistochemistry or for further molecular testing, depending upon the right morphology. So this assessment is most critical in giving you sense of the cellularity. It might so happen that I am taking the section for downstream molecular testing, but there is no tumor. So there are a lot of permutation combinations happen, and adequate tumor cellularity with minimum 20%, 10 to 20% tumor cellularity going in for further immunohistochemistry or molecular testing. And believe me, this aspect is quite changing a bit as we go on, and biomarker testing is increasing. It is so we always have gone with this notion that histopathological diagnosis is required first and then subsequently for any molecular testing, and we always believe that and this should be followed in terms of prioritization of your tissue. But now as we go to biomarker testing, you will realize your clinician might be asking that no need for this thing, you directly give us the molecular results. And if in a scenario where your molecular at times our molecular testing has to be prioritized, so we are moving in that line where there are requests that without even this histopathological diagnosis, though it is very very dangerous, I would agree, I would not recommend that going in directly for that, but there are requests where you have to do so many molecular testings. So the point that I'm trying to make is that we need to minimize the tissue loss to the extent which is possible, giving right diagnosis and subsequently using appropriate slides for molecular testing. And insufficient block cutting, or we have to be a little careful in terms of taking sections in this area. And so so histopathology, as a pathologist, they can they can set up the reflex cutting of sections which are required for both for IHC diagnosis and subsequently for biomarker testing. What happens is that there is a tissue block, and subsequently they would trim down 3 or 4 more sections for any kind of testing, and that leads to loss of tissue. So any sectioning further leads to loss of tissue. So if that kind of testing is available at upfront, and we take a call upfront in both in especially in biopsy small biopsy sections, so that would be very very helpful. And then keep these unstained slides or sections for further biomarker testing at the one time at single time point. And So this kind of reflex testing, cutting, prioritization, or thinking in terms of how we need to go about in our laboratory, how we need to there's a lot of issues. A lot of issues are there in the laboratory when you are prioritizing that, and the histopathology and molecular lab may not be on the same page in that aspect, but working together to be able to see that this thing is implemented in the best interest of the patients has to be done. And also, sections with the greatest tissue content should be reserved for molecular testing rather than IEC. This is what I was talking of. So as we are moving more and more toward molecular testing, we are seeing more and more requests where the tissue being prioritized towards for molecular testing, where your patient has an access to different molecular drugs available, because a lot of drugs are available. So you want to prioritize your tissue. So again, you have to work very closely with your histopathology and molecular colleagues to be able to maximize those results. So again, one area where so you are maximizing your yield, and there manual micro dissection can be helpful. And usually what you take is you take sections, you take and then append off, and then you have a cellularity, and then you extract your DNA or nucleic acid subsequently. But there's another approach there where you can do take those sections on a slide, and you mark your tumor area, remove your necrotic area through manual dissection, and this can increase the yield of your diagnostic testing a lot. So if in a small scanty tissue there is a 20 to 30% tumor is there, so this kind of approach is very, very helpful. Though sometimes it is very challenging to implement in high throughput laboratories, but if you are able to do dissection, it is helpful uh, to be able to get your good results, and your chances of getting positivity are very high if you're using in this pre-analytical phase. So the last thing that I mentioned is tissue blocks stored in appropriate conditions may yield adequate DNA for molecular testing after years. So whatever blocks that we have prepared, they need to be stored appropriately, as they are a resource material. They could be used for any kind of biomarker testing, maybe certain years down the line. And we have seen that if they are not stored well in appropriate cool conditions or cool standardized conditions, the yield decreases to the tune of 5 to 10% every year. So this yield decreases, and the quality also decreases if those are not stored well. So we need to be aware again that storage also has an impact on the molecular testing. A block which is freshly prepared versus a block which is 5 years down the line, it might have different results, and this could be because of only of the storage in the condition in which these blocks have been stored. They could have been kept at very high temperatures, and we would expect those results to work out after 5-10 years. It may not happen. So we need to take appropriate steps now, so that you are able to maintain those blocks for a longer duration of time, at least 10 years. Now, as far as NABL, you need to store all your blocks and sections, I mean, the nucleic acids for at least 10 years is what has been the recommendations in that. So, proper sample transport and communication also contributes to good testing practices. Sample transport is a important criteria. We whenever samples are coming from different parts of the country, if the container is not right, or the time barcoding is not right, this is the samples could be rejected if they are not accepted well. TRF, as I mentioned, the downstream part, I am not sure how many of us would be implementing, and this is channeled toward this only, to be able to see that if we are able to get this information right, right to the TRF, not only for our blocks which are being prepared, and these sections are this information is available to us for all those blocks, but even for molecular testing, if these kind of information is available, this could lead to sample rejection. and subsequently incorrect test. Of course, these are no need to educate anyone. So this has to be there. And taking all those, I think I mentioned a lot of steps, pre-analytical steps, and a lot of experts met. And this is a paper which came out in 2021 from a group of experts, and they have recommended how to handle and process in this era of molecular testing. There are, I would recommend all of you to go through this paper in detail. So there are around 19 experts met, and they have given a lot of recommendations of how to go about our for the tissue that we use. And I will just take you through the key steps. You can go through these things in detail in this paper. So, like with respect to the cold ischemia time, as I mentioned, that tissues must be fixed immediately to avoid degradation. This ischemia time should be less than 1 hour, should not exceed 1 hour, and this requires training of a lot of people, and those who are involved, we need to train them, maintaining a record of the time. This all should be done with respect to the cold ischemia time. Second is with respect to the type of biospecimen. So formalin fixed paraffin embedded tissues are the most preferred specimen for biomarker testing because they can stay for a longer duration, and tissue, so that you can store them for a longer tissue as opposed to your live tissue. So, and we need to have separate standardization and validation, not only for the FFP specimen for storage, we also need to have a for cytology specimen as well, which also are very, very critical. And having a block for those cytology specimens allows you to keep them for a longer time and allows you to use that material for any kind of downstream testing. Now, all those biomarker testings are available on these cytology blocks as well, but we need to standardize and validate, and then prepare those blocks and keep for our testing. So this is the recommendation with respect to cytology specimens. So as far as feasible, we need to prepare blocks and keep. And for tissue fixation, as I mentioned, it is most critical, tissue fixation. The fixative 10% neutral buffered formalin at a pH of 6.8 to 7.4 is the recommended fixative of choice. The date of preparation of formalin should be recorded freshly, and this formalin should be freshly prepared and within 5 days of preparation. So this is not to be too long or too old formalin that is prepared. So it is within 5 days of preparation. The fixation time to be recorded and controlled, a very key step. I'm not sure again how many of us record that fixation time. Because during my pathology days, we used to leave our sections and leave it for 3, 5, 4 days, depending upon the tissues that we receive. But we need to start documenting, and because if we start documenting and knowing, then only we will be able to control that. If we don't know how much our fixation time is, we will never be able to control that. So the recommended time for molecular testing, we know for our IHC and for other kind of specimens, this is the recommended time for molecular testing, so that the results are not compromised. So we require at least 6 hours for smaller biopsies, 12 to 18 hours for larger specimens, and fixation beyond 24 to 36 hours should be discouraged. Tissues with high fat content may require 48 hours, and for practical purposes, more than 2 days. Anything more than 2 days would be a problematic area. Particular care should be taken regarding fixing time for procedures conducted before a weekend or on a holiday, because they lead to overfixation and can impact those molecular results, especially colon results. As I mentioned, larger tumors, colon results, they are affected because of the overfixation. Transportation time special care to be taken for transportation time if the sample is to be transported to a referral laboratory. The pH of the formalin should be mandatory check, and if it is less than 6.8, it should be discarded as it leads to the degradation of the nucleic acids. The formalin fixation of tissue specimen at 4 degree leads to better preservation. And acidic or heavy metal fixatives or decalcified specimen should be avoided. for biomarker testing. As I mentioned, a different specimen block, if we are able to prepare both for IHC and molecular testing, would be the best thing that we are able to. With respect to the dimensions, the tissue section thickness should not be 4 mm for appropriate fixation, and the volume to the mass 4:1 at the minimum, and preferably 10:1 the volume as opposed to 1 and the tissue, with tissue completely immersed in the fixation that we are using. So this, we need to be aware of the tissue fixation specifically with respect to molecular testing, because we won't come to know in a molecular laboratory what has happened to the result. So we all need to be aware that everything affects the results, and the result is it does not work, it doesn't amplify, we have quality issues, we have the reads are little less, there are so many things that happen, and this if there is availability of this fixation time or appropriate fixation, can help control or avoid those kind of problems for biomarker testing. So with respect to the tissue processing, optimal processing time for core biopsies, as I mentioned, should not be less than 3 hours for smaller tissues, and 8 to 16 hours for, it should not be less than that. So anything between 6 hours to 36 hours is what is recommended by the group. Preferred dehydrating agent is isopropyl alcohol, and as I mentioned, standardized automated is preferred over manual processing, and this we all agree that this we are moving in line with standardized automated approaches. Details of the tissue processing conditions to be recorded. Even though we are recording that, we need to be analyzing that for in cases where the samples are failing. The solutions in automated tissue processes must be changed periodically as per manufacturer's recommendations. The tissue processing quality should be evaluated by checking the morphological features in addition to the optimal DNA and RNA yield. So tissue processing, and this is important. Then the biospecimen requirements. So again, with respect to the the paraffin wax, the melting temperature should be 58 to 60 degrees centigrade should be used. No tissue to be wasted. IHC to be performed only when deemed necessary, and it has to be a judicious use, specifically in small biopsy sections where we face tissue. Reflex testing is preferred over sequential testing, and block should be cut minimum number of times. Tumor fraction should be maintained at more than 10% for DNA extraction. So this varies depending upon the technique we use. If we use if we kind of use the high sensitivity assays, then 10% kind of is the minimum. If you are using low sensitive techniques, then you need higher tumor percentage, and we can increase the sensitivity and specificity if we do micro dissection and macro dissection to enrich the tumor content. If we are able to do that, then we can increase the yield of our biomarker testing. And for low cellularity tumors, specifically again around 10 to 20%, those are specimens with low tumor cellularity. So those kind of specimens, again, having those sections going in for tumor for any kind of molecular testing, we need to be aware that this is a low tumor cellularity specimen, and if it is negative, then the results may not be appropriate, and a note should be mentioned that this tumor has low cellularity. Again, that should be documented. Negative meaning it is not true negative, it would be false negative. If it is positive, then it is fine. So those kind of appropriate steps you need to be aware and take a call whenever you are dealing with specimens with low tumor cellularity. Again, that has to be documented by a pathologist who needs to evaluate the cellularity. Blind sections going in for any kind of molecular testing is not recommended at all anywhere. So this is another workflow where they have described so this is from the same paper where they have kind of described optimization of tissue handling and processing for molecular testing, and for histopathologicological diagnosis, minimum of 3 sections of 3 to 4 micron are sufficient. Minimum three sections. If additional IHC is required, then we require more tissue for sure. For fish based biomarker analysis, minimum of 50 evaluable cells should be there, and each test like each ALK or ROS or each test would require sections of 2 to 3 micron. So if you are doing fish-based biomarker, then minimum 50 cells and at least 2 to 3 micron sections should be there. And that is why if you are having access to NGS in these scenarios, it is encouraged to be able to go in for an NGS kind of a testing if tissue is an issue, because in this kind of sections and yield, you are able to get much more results. And we all are moving in that line where NGS requirements depends upon the panels used for routine diagnostic, and the yield our requirement is 100 to 150 nanogram, though this is on slightly on the higher side. This because there are two types of NGS assays. One is the hybridization based assays and one is ampli-seq based assays. The hybridization based assays, the DNA requirements are slightly on the higher side, but the ampli-seq assays work for lower DNA or nucleic acid requirements in the range of 50 to 100 as well. So we need to be aware that this is what minimum is required for doing any kind of lower biomolecular testing, and we need 3 to 4 sections of 10 micron thickness when we are going for NGS testing. So we need to be aware of this. Then for IHC based biomarkers, we require, and this is true for ALK, ROS, PDL1, minimum of 6 sections of 3 to 4 micron, including negative control for PDL1. And we require at least 100 tumor cells for PDL1. So this is what the recommendations are there for IHC based biomarkers. Then for RT-PCR based testing, as I mentioned, tumor content more than 20% is usually there. If you are using less than that, then using a high sensitivity assay like NGS or a ddPCR, and if it is positive, it is fine. If it is negative, then a note mentioning that this is what the issue is. We need to do that. And usual recommendation is to have 4 sections of 10 micron, and this would vary depending upon the platform. It could be Cobas or IDELA and the tumor content. So this could vary based on the requirement of different assays. So there might be different tumor content and required. So this is I think my last in the summary slides, where just trying to document the causes of failure. So whatever we have discussed, right from sample processing, the steps taken for cold ischemia time, subsequently fixation, block preparation, transport, labeling, taking out various tests. In the end, it comes down to the assay failed, and this assay failed because of various reasons, and this could be pathological failure, whether we are not able to find any tumor content. It also happens. It happens in around 20% of the cases. Majority of the samples, we don't have the insufficient DNA yield. So insufficient DNA yield, again, I've so many reasons I've mentioned. This could be because of so many reasons like fixation, cold ischemia time, lot of things are there. Apart from inappropriate kit, inappropriate technical issues that we do. So apart from that, there are other reasons which are pre-analytic in nature, and we can avoid many of them if we just focus on those issues. So almost 50% of them have extraction failure, and then we are helpless in terms of the laboratory. We all are helpless. We want to do so many things, but we are helpless with respect to the DNA not working. This is insufficient yield, and even if we get the DNA, it does not work out. So this is, you see, so many areas. I mean, test not working, either we are not able to extract or we are not able to amplify and not able to get the desired results. And most of the reasons, pre-analytical reasons, as I mentioned earlier, they kind of define this area, and we all need to work to be able to control that this thing. So I would summarize and would mention that for the accuracy of the molecular testing, the specimen has to be handled appropriately, and processing has to be done in the right way. And the pathologist forms an important core of the sample handling and tissue. We always know, anybody who's dealing with molecular testing or FFP can define that tissue has always been an issue, and we all need to work together to control that. The integrity of the specimens cannot be retroactively recovered once lost. So anything tissue which has been fixed, processed, and done, we cannot go back. And there are a lot of issues if we are trying. There are kits available with which you can try to do that, but nothing works in the range that we do if we are proactively doing or controlling all those steps. And there is a paper available, a publication which is there. You all can refer to that and take that help and see that we are able to minimize the pre-analytical error. So with that, I would like to come to the end of this session. So thank you so much. I would stop sharing, and any questions which are there, I would take up in the end. You can all put it in the chat box. I will go through in the end of the session. So thank you so much. So I will move on to the next presentation in this area. So next we have so we have a presentation with respect to the best practices. Dr. Vijayalakshmi, she is a PhD scientist. She is the head of professor and head in the Department of Molecular Diagnostics at Cancer Institute, Adyar, Chennai, and she has established state of the molecular art laboratory since 2013 and working in the NABL accredited molecular laboratory. More than 25 tests are there, and with more than 55 publications in this area. So I would request Dr. Vijayalakshmi to share her experience in this area. Dr. Vijayalakshmi, please.
Thank you, Dr. Neeraj. I'm sharing my screen. Is my screen visible?
Yes, I mean, not yet as yet. Yeah, now it is visible.
Yeah. See, at the outset, I would like to thank the organizers for giving me this opportunity. And it's really a great honor to be a part of this forum where I'm talking after Dr. Neeraj, because he has very elegantly described the pre-analytical variables which need to be standardized and controlled. And most of it may be a kind of an reiteration, but that's important because they are standard procedures and they have to be repeated so that all of us understand it well. But the context of my talk is more catering towards NGS and molecular methods.
Can you do full screen?
Yeah, 1 second.
Yes.
Yes. So we are all in the era of personalized medicine. And so why is it that what is the goal of this personalized medicine? It is the ability to identify patients who are likely to respond to a particular kind of therapy. So gone are the days when, it was an era of one size fits all. So now we are all in the area of personalization. So our growing understanding of biology and molecular signatures that we are deriving out of individual tumors, they have helped us to identify predictive biomarkers. And because of increasing predictive biomarkers coming up, we also have increased number of diagnostic tests which are being performed, which are often as serial or distinct assays. So because of, and especially when it comes to biomarker diagnostics, this whole field has been revolutionized by the next generation sequencing, NGS, which is able to provide a comprehensive overview of a genomic profile of a tumor. So because of this, what happens is the NGS results are affected by the pre-analytical variables. They can influence the accuracy and reliability. That is why it's very important to understand the standard protocols which need to be followed. So the standardization of the pre-analytical variables, it is again complicated by a lot of processes, which starts with, plethora of specimen acquisition. There are a lot of processing methods which happen, and all of this happen at different places, different labs. So because of this, what we call is a tissue journey. The tissue is starting from one place and it is reaching another place. That's why we call it as tissue journey. It starts with specimen acquisition, then specimen fixation, sectioning, as well as we have post-fixation processing, where we have the nucleic acid extraction, library preparation, the different choice of sequencing methods. All of this are important and they are critical for reliability of NGS analysis. Therefore, standardization is very, very beneficial. And as you all know, the cost of sequencing has decreased at a rate faster than Moore's law. So nowadays we can do a whole genome sequencing at the rate of, say, $1,000. So this cost decrease has also helped us to do more and more NGS in our care these days. Why precision medicine? Because it is helping us in predicting diseases. It is helping us to predict early detection. And then it is helping us to choose drugs, the right drug which will work for the right person. So right person getting the right treatment at the right time is possible with precision medicine. And then cancer treatment, in the era of cancer treatment, we are able to choose the best treatment to target the cancerous cells. And the genetic testing can also identify people who are at the risk of certain cancers. So it is helping in that way. And then it is also important to understand how genes are interacting with the environment. So it is the gene, the environment, the interactions, all this is able to, we are able to learn so much because of precision medicine. And then coming to lastly, the microbiomes, because microbiomes are also important, and the different patterns of these microbiomes are also linked to diseases. And now we have the technology to understand these microbiomes and their role also in precision medicine. So why pre-analytics? As Dr. Neeraj very nicely explained, that it is the first stage of total testing process. That's why it's very important. So it's the starting step. So if you have a junk inside, the junk will be out. So therefore, the entire sequence starts with the first step. The first step has to be the best step. So as he mentioned, the testing process, there are 3 phases. You have the pre-analytical phase, which has all the processes that occur before the actual analysis. Analytical phase is the actual testing which happens, and post-analytical is after the analysis of the sample is completed. So what are the key components? First is, of course, selecting the test that has to be done. Then the test is ordered by the clinicians. Then the patient is prepared. Then the sample is taken. Then this is pertaining to the blood sample, but if it is FFPE, then the biopsy is taken. Then the specimen handling happens. The sample has to be transported properly, processed properly, and storage has to be done properly. All this was explained nicely. So why do we need to understand pre-analytical factors, especially when we are using FFPE? That's because the molecular analysis of biospecimen is key to any diagnostic and therapeutic decisions, and FFPE becomes very important. Coming to certain key challenges for biomarker testing, which are there in India, there is a challenge pertaining to tissue acquisition itself for morphological diagnosis and ancillary biomarker testing. There are lack of uniform and standardized protocols for tissue management. That is why we are doing this session, where we are learning these standard steps which needs to be followed. And then there is excess reliability of cytology specimens, lack of a multidisciplinary approach, because there are too many people handling the entire test. So the team is just not pathologist based, but it has become multidisciplinary now. So the local practices, the ancillary analysis, all this can affect the tissue journey. So therefore, that must be taken into account. And then we also have quality and quantity related issues when it comes to biomarker testing. Earlier, it was only histopathology. Now there are other ancillary tests which are coming up. So therefore, the quantity and quality becomes critical. And then lack of facilities for multiplex NGS testing. Not every center has these facilities for NGS testing. Then higher throughput time. testing which is happening in referral laboratories, when you don't have an in-house facility and you have to send the sample somewhere to a testing laboratory and then do it, then those also become caveats there. Then the cost of testing, and then if something is not working properly, then you need to do a rebiopsy. That kind of opens up plethora of problems. And then lack of training facilities for molecular diagnostics. Not every center is completely trained in the field of molecular diagnostics, and lack of appropriate archival facilities. So these are some of the challenges that we are facing in India. About NGS, quickly, it is everybody knows about NGS, that it is a completely an established methodology is available through which we are able to screen and diagnose the germline, which is the inherited as well as the somatic genomic mutations. And there are, you have the whole genome sequencing, the whole exome sequencing, RNA sequencing, and then you have targeted panels. So based on what you want to look at, now we have the technology to do it. So the whole genome sequencing here is looking at the whole genome, so therefore has the highest coverage, which is able to generate information from the entire genome, which will also include the introns. And if it's whole exome sequencing, it is only restricted to the exome. Then you have the RNA sequencing, which is only focused on the transcriptome. So therefore, it gives you information about gene expression and gene fusion analysis. Especially in hematological cancers, the gene fusions are very, very critical. So you have then NGS assays also come up with targeted hotspot panels to comprehensive genome and transcriptome scale platforms. So these are all different kind of tests within NGS, within the umbrella of NGS, and each of them have different requirements of nucleic acid input. And that again depends upon the samples which we are getting from our pathology colleagues. So these can be used to detect specific genomic mutations, genomic signatures, including microsatellite instability, tumor mutational burdens. So all this can be derived out of this test. And then biomarker diagnostics may also benefit by combining a variety of approaches. Like you may have a situation where the genome profiling is done by MGS, whereas a mismatch repair deficiency is studied by immunohistochemistry, and both put together are presented as a report to the clinician. So you may have situations like that where two different kinds of approaches are combined. And then you can have a single biomarker diagnostics, which can actually, in those days, though it is single biomarker, can give you a more individualized approach. But nowadays we are in the era of comprehensive diagnostic potential of NGS, which we are trying to explore. So as I mentioned, your sample source in the pre-analytic phase stages, you have the sample source, which can be a tumor sample, and then you may have a normal sample like a control. So the molecular targets can be DNA, RNA, or protein. Analysis can be genomics based or transcriptomics based or proteomics based. And when it comes to proteomics based, it can be immunohistochemistry also. And then the output here will be whatever data that we are deriving out of the tumor. It can also be blood or liquid. So we can also do ctDNA sequencing. So in that case, it will be blood. And then then you have specific protocols for normalization. There are extensive bioinformatics which go for data analysis. And then you derive this biomarker determination. What your biomarkers could be, they could be the single SNVs, indels, CNVs, MSIs, TMBs. All these are the genomic information that you derive out of these tests. And then if it is RNA, it will be pertaining to gene expression profiles, which can be inflammatory. You can have immune signatures being picked up. And if it is tumor based, then you may have immunotherapy related markers, PD-L1, MMR markers. So all these are some of the biomarkers that are currently in practice. So what are the key steps to tissue journey, which include, tissues, as I mentioned, specimen acquisition, processing and preservation, nucleic acid extraction, and NGS library preparation. So tissue, when it comes to tissue, it can be a resection tissue, it can be excision biopsy, or it can be a small tissue biopsy. All this go to make your paraffin block. And then if your specimen is going to be cytology based, then you may have, it may be through the FNAC, or you could have the cells which are derived from urine or ascitic fluid or pleural fluid, sputum or CSF, whatever. So from there, you are going to either make a cell block or a non-cell block. If it is a liquid, then it can be a blood or a cystic fluid. And these will go to your more first step is assessment of morphology. The assessment of morphology happens either by histology or cytology, or you could have parallel diagnostics by immunohistochemistry, where we're looking at different markers. After the morphological assessment, this specimen will then go for extraction. So the extraction can be again DNA, RNA, or protein, and based on the different markers that you are desiring to do or different protocols that you're desiring to follow will happen. So all this involves a key. If you see, it's a team. You have a team of surgeons, pathologists, you have allied health professionals, you have clinical informaticians and patients. So everything put together, it's going to be a teamwork, which is involved in this particular exercise. So as I mentioned, if you are going to have a junk coming in, it will be the junk which will be going out. So therefore, we should look at what are the variables which affect the quality of biospecimens. As I mentioned, pre-analytical, analytical, and post-analytical, and it is a multidisciplinary team. And because it is multidisciplinary team, it can introduce errors at different levels. So that is why we need to control these errors. So some of the pre-analytical variables that affect the quality is acquisition, and processing. When it's going to be processed, as sir mentioned, we have specimen fixation, temperature, fixation time, pH of the fixative, post-fixation processing, and methodology. All this has been described. So if you see, if it is DNA, RNA, what is it that it is going to be used for? The sample is going to be used for DNA, then by and large, the DNA is stable. Right from your surgery till it is reaching the lab for a thing, the DNA will have a kind of a stable, it's kind of stable. Whereas when it comes to RNA and protein, the sampling is so important, because if your sampling is not properly done, the yield of RNA and yield of protein can drastically fall. But when it comes to protein, by IHC, it is still okay. You will be still able to detect the proteins. But when it comes to RNA, it is the most affected biomolecule when the processing is not done properly. So primary use of biopsy specimens, there are different biopsy methods, and then it will again depend upon the site and the size of the tumor. And so therefore, the least invasive method of biopsy is what we should be undertaking. So when it comes to surgical biopsy, it can be, as I mentioned, tissue biopsy, resection, or excision, but these are invasive procedures. Then you could have a core needle biopsy, which could be cytology specimens, which you will be getting via your FNACs. And then, so there has to be a standard operating procedure which should be established for transporting these specimens to avoid any errors or delays in tissue processing. So therefore, that flow should be properly decided. And then direct preservation of the biopsy materials should ideally follow controlled and defined method. The formalin fixation and embedding in paraffin should begin within 1 hour of removal. As sir mentioned, the short cold ischemia window is very important. And then there is a specified amount of the adequate volume of the buffered formalin should be used, and then the fixation time, which is approximately 16 hours. All this has been covered. And then formalin FFPE blocks, inclusive of cytology cell blocks, should then be sectioned. And then we should always have some extra sections cut to avoid tissue wastage, because you have other ancillary tests which may be coming up. So you don't want to waste the tissue. So you should have extra sections maintained, and all the protocols have to be standardized. And it is important to support reliable and reproducible H&D assessment also. And then the procedures at this stage of journey are always informed by collaboration of surgeons, intervention radiologists, surgical and molecular pathologists, cytopathologists, and clinical oncologists. All of them have to work in cohesion, and there has to be a collaboration. So this multidisciplinary communication becomes very important to optimize the specimen acquisition and processing. So various cytology specimens can be used. You can use smears, liquid-based cytology. You can have cytospin preparations. You can have FTA cards and cryopreserved cells, whatever. All these specimens can be used for molecular analysis. And the technical requirements and features for each preparation will differ. But what is most important is whatever the specimen is, the quality and quantity of the extracted DNA will extensively rely upon adequate pre-analytical assessment. So therefore, it is recommended that the NGS-based testing incorporates non-cell block cytology specimens, and a cytopathologist is consulted as an expert to inform the validation. And as I mentioned, there has to be a communication between the molecular laboratory and the biopsy team. So the key pre-analytical requirement for any reliable biomarker analysis is that the tissue specimens should be of sufficient quantity and sufficient quality to permit morphological diagnosis as well as biomarker profiling. So you should have that much of material available. And in addition, although biopsy methods of choice are primarily based upon patient safety, the optimal procedures and diagnostic setting should also strive to obtain sufficient material. Morphological, you should have enough material. Again, I'm saying that for morphological diagnosis as well as for downstream biomarker assays. Then the molecular profiles can always get affected when you have intratumoral and intertumoral heterogeneity. So those should also be taken into account, and that is where the pathology colleagues will be extremely helpful to tell us the representation of the sample. And these factors are important for NGS. And then the tumor fraction, it's very important to document how much of tumor fraction is present in the specimen, as also known as tumor purity. And if it is below a certain standard, then it is better not to use the tumor if the representation is not adequate. So therefore, a molecular pathologist with anatomic and cytopathology training will be particularly useful at this stage of the tissue journey, which will optimize the tissue triage and will also help in guiding the nucleic acid extraction, which will help to carry out the downstream processes with ease. So the successful NGS is generally lower in smaller specimens. So if you have very scant material, a core needle biopsy or cytology specimen, then the yield will be lower compared to larger specimens like resection and excisions. And also some tumor types may have like low cellularity. So that also should be taken into consideration. And then the necrotic regions can also affect the nucleic acid yield. So the NGS readouts are usually considered like reliable from specimens if you have a tumor fraction and a surface area greater than 10%. That is, if the tumor fraction should be greater than 10% and your surface area should be like at least 5 millimeters square. And then the NGS requirement for nucleic acid input will again depend upon the platform that you're using, the gene panel that you're using, and the methods and the target of enrichment that you're going to be following. So this has been covered again. So optimal fixation is for about 8 to 24 hours in 10% neutral buffered formalin. And then it has to be sectioned properly, at least 50 micrometer section thickness. And, individual section should be less than 20 micrometer for optimal DNA extraction. And it has to be evaluated by a pathologist to determine its accuracy. As sir mentioned, without the pathologist's evaluation of the specimen, it is very dangerous to directly take it for NGS. And then the pathologist must determine whether the specimen contains sufficient neoplastic material. That is very, very important. And enough tumor cells, which is greater than 1,000 for a particular NGS-based test or any molecular test base to be carried out. So tissue processing, this has been covered already. Cold ischemia time, tissue thickness. We have looked at the fixation buffer, fixation time, and ratio of fixation buffer volume to tissue volume and storage condition. So these have been covered. So tissue has to, if it is FFP tumor tissue, it has to be stored appropriately. And then for tissue processing, we have looked at what time should be followed. So these standard protocols need to be followed. And yeah, so ultra low temperature freezing is normally linked to a superior preservation. But if you excessively freeze it, it can damage the morphological features. So there are two opposite features. If you freeze too much, the morphology will get affected, but the DNA and RNA may be intact. So there has to be a balance between the two. and then what type of fixative you're going to use. So that we know. And then the tumor sample, sometimes certain tumors will have lot of heterogeneity. So those have to be kept in mind, and that is why we need a pathologist to let us know the representation. So if you there is a lot of effect of formalin on DNA and RNA. That's why that time has to be maintained. If there is, because when you put your specimen into formalin, what happens is there is a lot of cross-links which are being formed. So the more cross-links that you have, the more prolonged formalin fixation will lead to more number of cross-links, and this cross-link will lead to more amount of purification that will go into to get good quality of DNA and RNA. So that becomes challenging. So therefore, that is why the time has to be maintained properly. So though formalin is kind of recommended, the formalin, as I mentioned, can cross-link. And because of cross-link, if the cross-links are not removed properly, then the yield of DNA that you get will be altered. So people have suggested methanol fixation as an alternate option, but that also leads to, higher, though that has been shown to yield higher quality of DNA with a longer fragment size and more accurate copy number, but still FFP specimens, calling than FFP specimens. So though methanol fixation has been promoted, but still because we are using FFP specimens, formalin is still preferred. There are also other fixatives used like picric acid, mercuric chloride, tannic acid to enhance tissue penetration. And but their role in functioning as a DNA preservative agent is questionable. So therefore, the tissue preservation variables to be considered are temperature, pH, and fixation time. Fixation at room temperature can lead to more DNA degradation than at lower temperatures, and immediate fixation at lower temperatures therefore recommended. So these are again...
Dr. Vijayalakshmi, sorry to interrupt.
Yeah.
Little short of time in that area.
Yes,
so
yes, sir. I will probably, I
No
think
problem.
these are
No
many
problem. I
of
just
these
thought
are
of
reiteration. I will skip these slides because you have covered it in detail
Yeah.
already.
maybe in
pH
2-3 minutes.
fixation
you can-
time, optimal fixation time. So as you mentioned, this NABL accreditation tells you that the histopathology blocks and slides have to be stored for 10 years. And then you have post-fixation variables also, where a pathologist is required to direct us to tumor-rich areas and viable tumor cells for good and sufficient nucleic acid yield. So I will quickly go to what we are kind of facing in the lab, few things that we follow. This is more pertaining to the NGS, the different two kinds of platforms which are commonly in use, like Illumina and Iron Torrent. So I have just mentioned about the difference in the two platforms. So this I will not go into detail. So this slide talks about like if you do a QC assay based upon if you have a normal genomic DNA and if you have an FFP where most of the DNA with a template of more than 200 base pair and less than 200 base pair. So how this particular, so if your low delta CQ is lower, that means the quality of DNA is good. For higher, it is a poor quality of DNA. And then we have different QC steps that we follow for after every extraction. So for every NGS experiment, you need to do a qubit based and a tape station based QC assessment. So this is an example of how a degraded RNA looks like in a tape station output. So when the sample DNA or RNA breaks down to smaller fragments, then this is a kind of peak that you would get. So generally, if you have a closer the peak to the lower marker peak, that means the degradation is more. So this is something that you do. You have different QC steps to assess your quality of DNA. So anywhere, if you feel that your quality of DNA has got affected because of any of your pre-analytical steps going wrong, you can halt. You need to halt your procedure at that particular point of time. So here again, how the degraded genomic DNA looks in the tape station file is shown. So these are some of the, based on the recommendations from Illumina, how you follow the quality standard for the NGS experiment. So this is something what we do in the lab is we have made a kind of a sample sheet. So these are some of the parameters that we record, like for every NGS exercise, in every NGS testing that we do. So we have the date, the UHID, the patient's name, sample type, and how many sample quantity, how many we have, then what extraction method has been used, and what extraction kit was used, and what is the expiry date, what is the lot number which has gone into place, and what is the elution volume that we have got, and what DNA concentrations we have got in qubit and in the tape station. So this is kind of recorded. So whoever is doing it will record it, and then this will be evaluated. So this is again another example of sample processing sheet. So day 1 and day 2. So you have the DNA concentrations mentioned. So every sample will have an ID, sample ID, the DNA concentration and DNA dilution that you have made. For a 200 nanogram, how you have made the dilution, what indexes have been used, and what is your whole genome concentration that you have derived. So these kind of documentations help us to identify a specimen. If it is not worked, then we kind of halt it there and then don't take it further. So throughout the tissue journey, one has to look at the quality, specimen preservation. So this is all reiteration. I will skip this slide. And so how can we prevent these kind of, how to kind of assure quality is, to have whatever is the standard protocol, like sir had suggested a set of guideline, a publication which has been given, optimization of tissue handling and processing. So this is a practical recommendation which has been given by a multidisciplinary panel of Indian experts. So whatever guideline they have followed, it is better we follow those. So summarizing, we need to have a careful consideration of optimal pre-analytical techniques. And again, a multidisciplinary team is involved. So one has to be taking care of the specimen preparation, and the entire management has to be effectively standardized. And we need to minimize this pre-analytical variability across this tissue journey. And that is how we will be able to generate accurate biomarker analysis. So it is not a single whistle which can have a symphony. It needs an entire orchestra to play it. So I once again reiterate that it is a particular, it's a multidisciplinary work and a teamwork which will help us reach a better patient management. Thank you for the opportunity.
Thank you, Dr. Vijay Lakshmi, for nicely highlighting your practices, whatever you're doing in your laboratory, and how those are having an impact upon the assays that you're doing, especially the NGS assays. Very nice to know that. And so we move. I think there was one questions was there with respect to how do you check whether the FFP is going to work for any molecular assay, and you have very nicely explained. I think that question is answered very appropriately. So we move on to the next session, and the next session is by Dr. Suruchi. And request you to please share the.
Sure. Thank you.
Give me a minute. Dr. Suruchi, give me a minute.
Of course, thanks.
So Dr. Suruchi is the very prolific speaker, and she is the head of scientific affairs at MedGenome Labs, and she has done a PhD in human genetics, and subsequently she has worked in ACTRAC Mumbai for quite a long time as a postdoctoral fellow, and she has been very, very active in a lot of webinars, seminars, and taking care of a lot of pharmaceutical partners, B2B clients, sales, and scientific affairs. And she's been integral to the development of a lot of NGS assays at MedGenome. And I would request Dr. Suruchi to help us take us through this learning through your best practices. Dr. Suruchi.
Sure. Thank you so much. Thank you, Dr. Neeraj, for kind introduction. And I would like to thank organizers for giving me an opportunity to present and share the thoughts. Just sharing my screen. I think most of the I think the most of the highlights have been spoken and very beautifully highlighted by Dr. Neeraj and Dr. Vijay Lakshmi. So I would not go into that much. However, I'll just share the lab experience that we are having here at MedGenome and probably just some of the nitty-gritties that we would like to highlight in this session. So just give me a moment. Yeah. So I also just, wrote what all pre-analytical challenges that we have in using FFP tissue for somatic testing. And we have discussed in detail that it could be some fixation artifacts, which could be due to delay in fixation or duration of fixation or formalin concentration quality, which actually affects and actually fragment DNA and RNA. It could be a good procedure to proceed to actually kind of preserve the proteins, but for DNA and RNA, it is not a very friendly method, and it can introduce cross-links leading to lower leads. And sometimes it also induces a DNA damage, just like deamination of cytosine bases, which may introduce some kind of errors which can be read as mutations during NGS assay. So this is also very important. And these fragmentation, cross-linking, and chemical modification also results in unamplifiable DNA. So even if we have a quantity of DNA which is extracted, we may not have that quality of DNA which can be amplified during NGS technique. And again, temperature duration has been spoken about a lot. Age of the samples, the older FFP samples may exhibit more significant degradation as compared to the lower ones. And we usually tend to use an year old or not more than a 3-year old FFP specimen. And then I think we are very clear on this part that tumor percentage or the tumor cell percentage in the tissue block that is being used for NGS test is very important, and it should be above 20%. However, in India, it is very difficult to get more than 60-70% of samples which are above 20% of tumor content. So during the validation of next generation sequencing assays, we should make sure that our tumor content correlation has to be made with the limit of detection that we are going to offer, or the depth of assay that we are going to generate, and the amount of data
I think Dr. Surushi network had issues there.
Yeah, I think I can you can call her, Srikanth, 1 minute. You can just check with her.
I
if
just
she's-
check her, sir. Yeah.
check with, she can connect in a minute or two.
So she's facing some network issues, sir. So
Okay.
meantime, we can start with Dr. Lavanya's session, sir.
Okay. So I think if we can just introduce Dr. Lavanya. Just a minute. So Dr. Lavanya, she is PhD in human genetics from Adyar Cancer Center, and she's been working as a senior scientific officer at Indo-American Cancer Hospital and Research Center, Hyderabad. And she's established a molecular diagnostic lab in oncology, genetics, transplant, and microbiology at Apollo Hospital, Chennai. And subsequently, she started the molecular lab at Indo-American Center in 2014. And she's been actively involved in molecular diagnostics since quite a long time. And 2021, she was selected as an international assessor for EMQN network for assessment of lung and MSI schemes. and she has been a part of scientific review board of EMQN as well. She has more than 20 publications and has been involved in more than 4 projects with respect to the molecular diagnostics. So I would request Dr. Lavanya to share her experience with respect to the pre-analytical part of that. Dr. Lavanya, please.
Thank you very much, sir, for the warm introduction. Let me share my screen.
Yes, please.
Is the screen visible?
Not as yet.
Is it visible now?
Yeah, now it is visible.
Okay. So it's visible, sir.
Yes, it is visible. You can put it full screen.
Somehow it is missing here.
Right, the lower down.
No, there is a funnel kind of symbol is there. You can click on it. 65. You can see the 65, right? Just below 65.
No, cannot.
So
Can someone help me out that?
no, you can on the right side, right hand side, below the dot that you see, there are 3 things which are there. Where 65% is written, near to that. Right corner, right corner of your screen. Right corner. Focus on the right corner.
Yes.
Near to that 65%, that you need to click on that. Zoom in, zoom out. Right side, right side. Can you see that?
No, sir.
No problem. Then you can
If they
continue.
have the
No problem. You can start like that. No problem. Can continue. You can. We can see your slides.
Is it visible, sir, now?
Yes, it is visible.
Okay. Thank you very much for the opportunity and thank you, sir, for the warm introduction. Here I'm directly a lot about the NGS and the pre-analyticals have been spoken. Just keeping in mind the time, I'm just going to highlight the experience we had when we have started the journey of the molecular in Basavatarkam, what are the issues we have faced and how we have identified it and how did we rectify it. So now the session goes like this: what are the pre-analytical challenges we have faced, identifying it, rectifying it, and how this rectification has shown the output as our success story, and what is the impact of the results it had on the testing. So biomarker testing journey, we have started in Basavatarkam in 2014. Here, I would say that we have not started with the NGS. We have started with real-time PCR way back 10 years ago, a decade over. So here I would say I will take an example of EGFR testing by real time as our experience and take you through the journey of the identification of the errors in molecular testing and how we have rectified it. So now in this decade ago, in this decade, we had done EGFR testing on more than 3,800 samples. And when we started in 2014, for the first 6 months, we were like constant and routinely following the procedures that this is the 5-micron section and this is the extraction protocol and this is the PCR protocol given by the company. So we were following the same protocols irrespective of not bothering about identifying the errors or the rejection rate of the samples. Then after 6 months, we have started identifying the problems. We noticed that deparaffinization of the blocks, especially those which have come outside the lab. We work in a hospitalized center. So we are actually blessed to work with pathologists who are very much aware of the pre-analytical problems which can occur for molecular testing. And they have cooperated so much that most of the pre-analytical errors in the lab specimens doesn't occur. That means the fixation time, the block saving and the storage, as well as the tumor percentage, how when they are deciding after the morphology has been diagnosed, according to the tumor percentage, they will decide if the blocks are, there are 2 blocks, they will decide which block will go to IHC and which block can go for the molecular testing. So that part is very much streamlined. But after that, what is happening? When it is coming for the molecular testing, what is happening? Still, are there any problems in molecular testing also? Yes. When we start with that, then we have observed in the extraction protocols, deparaffinization was not complete for the tissues. So, and when due to that, what will happen? Alcohol was not an issue. And how we did the tissue conservation, how we modified the extraction procedures and the PCR reaction also to get a better results, and what are the alternative samples we have taken to test it. And so deparaffinization and alcohol. When we observed that, especially from the outside blocks, deparaffinization was incomplete, then the yield of the sample was very low, as well as at the same time, the alcohol when the
Dr.
yield
Lavanya, your
was low.
slides are not moving. Shall I share your slides if you're okay?
Yeah,
We'll stop sharing it.
okay.
Can you please stop sharing it? I'll share it.
Sure. Share and how to stop?
You stop sharing it, ma'am. I'll share it.
No, there's no.
Lavanya, on top you will get one green color thing, no? Stop share. Just click that. It will be red and green.
No, wait, 1 minute.
Now it is fine.
Yeah.
Shrikant, you can share the slides.
Let me know if my screen is visible.
Yeah, screen is
Yes.
visible.
Yeah, ma'am, which slide I have to go now?
Third.
Is this the
Yeah, no, that's over. And after that, we come to the 4th slide. Yeah. So the pre-analytical areas we have identified the problems are these: deparaffinization, alcohol, and how we have done the tissue conservation, and what are the modifications we have done in the extraction procedures, and the PCR reaction also. And we have done a study on alternate samples for EGFR testing. So that's that I'm going to share now. Next slide, please. So where we have observed, especially from the outside blocks, that the deparaffinization with the xylene was not proper. There was always some wax remaining in the process. So incomplete digestion was always happening. Due to that, what has happened is the yield of the DNA and the purity has decreased, which has inhibited the PCR completely. And this in the lab also we have faced when they have changed the company of the wax. Again, even in-house blocks also, we face this situation. When we identify this problem and we have shared with the pathologist, they have rectified that. The second problem we have faced is the alcohol. When the absolute alcohol label was there, but it was not, we are not able to get a pure DNA. When we have changed the alcohol company with the other company, when we compared it, then we came to know that, oh, it was mentioned absolute alcohol, it was not absolute alcohol. So that is the reason that the purity of the DNA is also reduced. Due to the purity of the DNA reduction, the again inhibition in the PCR has come, and the reduction in the PCR efficiency has also decreased. So these two main factors we have identified in the, especially seeing the DNA concentrations and the DNA purity. So these these will also inhibit not only the real-time PCR, even in NGS also, due to higher deamination, or we can have a lower reads, and the depth coverage will be low. When you see in terms of the real-time PCR, you will observe that fragmented DNA amplification efficiency reduction in terms of CT values. When you have a higher CT values for the control itself, that means for you will have a control. Sorry. You will have a control gene to be amplified before the mutation gene in a PCR, real-time PCR. If the control gene amplification itself is crossing more than 30 CT, that means you have a higher fragmentation of the sample or other inhibitors with a lower yield of a DNA or a lower purity of a DNA. So with a control gene CT value, you will be able to identify whether the DNA sample of the particular block of the patient is amplifiable or not, and whether that can be reported for the mutations or not. Next slide, please. Yeah. So how did we do a tissue conservation? As Neeraj sir said that the tissue has to be conserved. When there are tissue is more, 2 blocks can be made and the 2 blocks can be divided for IHC and for the molecular testing. Depending on the tumor percentage, if it is greater than 10%, it will go for NGS, and if it is less than 10%, it is referred for the real-time PCR. At the same time, section cutting, and if it is a single block, especially single block, section cutting is done at the same time for the IHC, for ALK, ROS, as well as the EGF molecular testing. Extra sections are also cut before that. Extra two to three sections will be taken on the slides individually, so that if someone needs a repeat, they can take it. And also what we do is we preserve the trimmed sections. Here, what we need for a molecular is a rolls, not as sections. So mostly what we do is the trimming part, when they do, that also we try to take it and take it for the extraction process. So that will, and that way we are actually including more tissue, and your DNA yield also will increase. So section thinness, mostly the standard guidelines are should take 10 microns or 5 microns. But what it happens is, you, according to the extraction procedure, what you're adopting and the kind of the kit, is it specific for a blood? Is it specific for FFPDNA? Or is it specific for a fresh tissue? That you have to see, and then take the sections accordingly. We usually take 3 micron sections for that, so that it is easily digestible, and you'll get and quickly digestible in a lesser time. With a less amount of xylene and alcohol treatments also, you get better yields. That is what our observation is. Next slide, please. So then I have experienced that when we started practicing, participating in EMQ and IQUAS programs in 2016, they have sent us only one single section for one test. That is 10 micron section they are sending us. And with that 10 micron section for one single patient, you have to do completely the EGFR testing. I was surprised. Actually, one section, how can you do that much? But the yield, what we got from single section was not more than 50 nanograms. So 50 nanograms, they are saying like 20 microliters, 50 nanograms, they are advising us to do a real-time PCR and NGS on that. Then my thought process has changed. When they are sending that, and with a single section, when we are able to participate in the IQUAS and we are able to get a good scoring in the IQUAS, why not try in our samples? So we have tried in our samples, we have tried reducing the sections. Along with that, what I have done is I have changed the extraction protocol depending on the sample type, like bone, EBUS, TBNA, or cell block, or lymph node. If the digestion, especially the xylene and the alcohol digestions are not good, we have to either repeat or reduce it according to the volume of the tissue and the kind of the tissue. And the subsequent purity steps have also to be modified depending on the tissue yield you are getting it. That is one thing we have done. And second thing is, according to tumor surface area, that is the larger tissue or a smaller biopsy, we will change the amount of the reagents to be used for the extraction process. And if it is an outside block, again, the same protocol will be implied. If the tissue is not properly digested, we'll try it again once or twice. And then this all we have done first initially experimented. Then when we have got the results, then we have implemented on the patient samples. For the outside blocks also, depending on the tissue volume, we standardize the extraction procedure. After the extraction procedure, next slide, please. So we optimize the PCR reaction. What does the optimization of the PCR reaction means? Here, any company, most of them, they use a company standard real-time PCR protocols to do a EGFR testing. So they say this is the amount of the DNA we need, or this is the minimum amplification control CT curve we need. But that is not the way. We can actually standardize it. It is not actually in the what I have observed is there are already suggesting higher amounts of DNA in the actual PCR to be worked. We have tried on a lower amounts of a DNA and increase the PCR efficiency so that with a lower amounts of DNA, suppose they have advised us 1000 nanograms, we started using 500 nanograms. And we have compared the results of the controlled CT as well as the mutant CT values. It was the same, similar. So not much of a difference. So then we started implementing that, and the results have improved a lot. And your reagents have also have reduced, and we were able to use on more number of samples that way. That is one factor. Other factor we have taken into consideration is that the tumor percentage. How much of the tumor percentage you need to do it. We now, after standardizing all these procedures, we were able to report even on 1% of tumor percentage sample, we are able to report the real-time PCR results now. So what we have done in our experiment exercises, post preanalicals, that is post fixation, we modified the extraction procedures and the PCR procedures according to the type of the sample and according to yield of the DNA, the PCR reaction setup was changed so that your amplification efficiency has increased. That is the thing we have changed. And what happens when the DNA concentration was too less? We have to do minimum 8 reactions, and we are getting very, very less DNA of only 500 nanograms, which will be sufficient for 1 or 2. So what we have done is we have chosen a driver mutations. So that driver mutations positivity rate is higher. That is 80 to 90% will be deletion 19 and L858R. So we thought we better give a chance and see whether they can be picked up. I don't believe around 5 to 7% of the cases, they were deletion and L858R positivity has come when we have done only control, deletion 19 positive and L858R. So the patients, especially the Arugishik patients, got benefited with some therapies. And I actually followed up the patients also, and they were doing on Jeftinib and Erlotinib also for 4 to 5 years. I had a follow-up. So if the DNA is very less also, try to do at least a driver mutation so that some answer comes out from some result can be given with a lesser amount of DNA for that particular sample. And if it is good enough, a medium, that means DNA is sufficient only for 4-5 reactions, then what we do is we do a driver mutations, deletion 19, L858R, T790M, and the insertion first. Then comes the G719X, S768, and L861Q. When it is sufficient, all the mutations will be done at the same, or irrespective of no choice will be taken for the mutations. Next, please. So there are some interpretation problems also. What will happen is in the real-time PCR, they will ask you to see a delta CT. Delta CT is nothing but a mutant CT minus the control CT, which cutoff should be less than 8 for most of the mutations given. But is it the standard protocol to follow? I would say no, that is not the right way, because your control CT value varies with your type of the sample and the amount of the DNA you have got it from the sample. So if it is that way, then you have to optimize your CT values, CT value, the delta CT value, you can consider it or not. Definitely, when you have properly optimized, when the control CT is 28 and your mutant CT is 32, you can still go and report it. But what you have to see is not the CT value alone. You have to see the amplification efficiency curve. That means the amplification curve, how good it is with an FFP sample. If you are able to identify that amplification curve with a good amplification curve and still with a higher CT, you can go for it. But you have to increase your confidence levels after doing certain amount of study on these kind of borderline cases. So my suggestion is, when don't go by only a company protocol, go according to your lab standardized protocols, so that you can offer a better benefit for the patients when the samples are very, very less and the patients even cannot afford for it. So this way it has helped us. And these all changes brought us the EGFR positivity rate. Before it was 40%, and after all these changes together, when they were implemented, it has increased to 47.2%. And the rejection rate, especially when we have taken 2 mutations and the changes in the protocols of the extractions and the PCRs together, we have come down from 9% to less than 2% now for the rejection rate. And what are the alternative samples? I had a thought, like, next slide, please. So I had a thought, like, what if the sample is failing completely? Is there any other sample we can use it? So I had searched my literature and said that, and found that pleural fluid sample especially can be used as directly the fluid without staining it. You might ask, like, without staining and seeing the morphology, how you'll do it? Not without seeing the morphology or staining. You will, after doing the pleural fluid, they will always prepare a cell block, and they will see the morphology and they'll report a tumor percentage on that. After that, whatever the fluid is preserved, we'll take that fluid, then we'll go for the extraction of the fluid directly and do the PCR on that, and then we'll do that. And then we have actually done a comparative study of the FFP blocks and the pleural fluid of the same patient, where we had around 120 samples we have done, and we have found 100% concordance between the FFP samples and the pleural fluid samples for the EGFR testing I'm talking about. This is the study we have done, and this paper is under process of publication. And the other sample we have tried is an FNAC, unstained FNAC sample for a biomarker testing. For this, we randomly have taken the thyroid sample, the FNAC lymph node, as well as the lung lesions and everything. When we have taken that unstained FNAC, stained FNACs will always be there for the morphology.
Dr.
And for
Lavanya, could you please summarize
Sir,
into it? Sorry to interrupt.
no,
Please.
sir, this is the last.
Thank you. Sorry.
No, sir, this is the last. So this can actually help us that though we don't have the FFP blocks, we still have a chance to look out for the other alternative samples also. And still higher technologies, you need not only NGS, you can see for the ddPCR also, there is a technology where the rejection will come down for the samples. This is our experience. Next slide, please. So as I'm an assessor, what did I learn in the international experiences? How well we can do. We had 25 countries, we have 234 panelists, assessors. We have seen more than 600 laboratories in that. In that, we have seen how good we can do a gene paneling, and what are the different procedures the lab adopts for different extraction protocols, different PCR protocols, different NGS protocols also, that has improved the yields. Those experience I have gained being an assessor, sir. And how good we can report, like most of the time they try to report in only 2 pages. So that is what, like, confined information, most precision information within a 2 pages, that is what they recommend for the international reporting formats.
Thank you.
Thank you.
Thank you, Dr. Lavanya, for sharing your experience, specifically with regards to optimization of those assays. So without wasting much of time, I would request Dr. Suruchi, whom we lost in between because we're running short of time. I would request Dr. Suruchi to, quickly, within 10 minutes maybe, if
I'll
she
just
can.
take 5 to 7 minutes.
No,
Thank
please,
you.
when you can take care, please.
Yeah,
Thank
no
you, Dr.
problem.
Suruchi.
Thank you. Thank you so much. Yeah, is my screen visible? Yeah, I'm so sorry. I could.
Yes.
I just got lost. Some issue in between. So I was just highlighting that that the validation of next generation sequencing actually is very important to understand what is the percentage of tumor cells can be used in the block, and accordingly the limit of detection and data to be generated, depth and other things can be decided, and the quality parameters can be decided. So we all have actually looked at it. So just, What are the sample requirements for NGS? I think this also has been highlighted. However, just going quickly through it, that about 100 to 500 nanogram of good quality DNA we require, and we need to check the quantity and quality. And FFP block, as we mentioned, not older than 1 year. And for RNA, also we require about 100 to 300 nanogram of good quality DNA. Just to highlight, if you look at this graph, so these are the DNA integration profiles of different samples. So if you see blood DNA profile, and it is very clear here that we have a good size fragments here, very good size fragments here in the blood profile. And when we move to FFP block, we see that there is a greater percentage of fragmented DNA as compared to blood. And another FFP block, which is apparently a very poor quality block. And here we have most of the DNA in the fragmented state. And here also we have just a ladder-like formation, and here also it is fragmented. So out of these, this is still
I think I think
Yeah, there are network issues with Dr. Suruchi. I think uh,
I'll just call her and confirm, sir. If she's okay, we can like conclude that entire
yeah,
session.
yeah, I think so. I think so. Yeah, just take a minute. I'll summarize everything.
Yep.
Yeah. So okay, I think we have lost Dr. Suruchi, and I would like to summarize whatever we have learned. We have had a very informative session with respect to learning from different aspects of sample handling, transport, processing, fixation, time, cold ischemia time, even the FFP type, that also we learned from Dr. Lavanya, and how this is helpful in with Dr. Vijayalakshmi highlighting the QC part, and even as Dr. Suruchi was trying to highlight the DIN number and the RIN number of the nucleic acid. So somebody asked this question, how do you know that this sample is good for molecular pathology or not? So we extract the nucleic acid and do the QC by either nanodrop or a qubit, or using tape station, where we get DIN and RIN numbers. And there is a publication from Dr. Anuradha where they define that DIN more than 5 and the 5 nanogram per microliter, yield more than 5 nanogram per microliter. These are type of specimens which work very well on an FFP specimen. So this kind of QC procedures work in line with the pre-analytical things that are there, and you are able to get your results very right. So that was the summary of the things that we have learned, with some practice sharing experiences as well. So I would like to thank all the speakers, faculties for sharing their time out, and delegates for being there. And I think most of the questions I've answered within these sections. There was a question with respect to minimum requirement for RT-PCR based EGFR assays. I think that Dr. Lavanya tried to highlight, minimum requirements for RT-PCR based assays. So they can work at even low tumor cellularity and very low DNA yields as well. So I also would like to thank Shrikant and AstraZeneca team for supporting us, for helping us conduct these sessions. IAO for organizing this meet. Anita organizing all these events in the background. There is a team which is working along with AstraZeneca to be able to see that we are able to get that things on. So this is the last session, and we look forward to coming in the next year as well with more webinars and more information to all of us. do write to us if there are any concerns, issues, and you are all invited to the Molecular Pathology Annual Meeting, which is going to be held in CMC Vellore from the February 13th to 15th, 2025. You are all invited. You can log on to the MPICon 2025 website and register. There are a lot of workshops and a lot of faculties are there. So thank you so much. And the slides, I'm told, will be shared. This is there in the live on YouTube. Session will be recorded and kept. Any more sessions, discussions can be personally emailed, and we'll be happy to get back to these results. So thank you, everyone. Thank you,
Thank you
Shweta.
all. Thank you all.
Thank you all, everyone. Good night.
Thank
Bye-bye.
you.